Next, I would like to introduce Dr. Conor Steuer, who's an assistant professor in the Department of Hematology and Medical Oncology here at Emory University. He is a medical oncologist specializing in the care of aerodigestive cancers, mesothelioma, and thymic malignancies. Dr. Steuer's research is focused on investigations of molecular biology and genomics of thoracic and head and neck tumors in order to be able to better further the care for these patient populations. Today, Dr. Steuer will be presenting disparities in lung cancer outcomes. Conor, I'll turn it over to you.
All right. Well, thank you very much for having me. Those were a great couple talks, and just seeing Dr. Carthon did a great job explaining kind of Winship's outreach to close these gaps. Hoping everyone can see everything. So some of the similar vein of what Dr. Carthon and Dr. Brawley talked about, but I'm going to be focusing on lung cancer, specifically disparities in lung cancer. Okay. So just to start off with, for those of you that are not as familiar with lung cancer, so lung cancer remains the leading cause of cancer-related death worldwide and in the United States, and 80 to 90% of it is tied to tobacco use. It's important to realize that more people die from lung cancer than any other type of cancer. That's true for both men and women. And a nice stat I like to throw out to my colleagues is that there's more lung cancer death from breast cancer, prostate cancer, and colon cancer combined. About 230,000 people are going to be diagnosed with lung cancer in 2020. About 70,000 men and 63,000 women are unfortunately estimated to die in the USA from lung cancer. Large reason this is that 70% of these patients will be, when they're diagnosed, with advanced stage disease at the time of diagnosis, and the 5-year overall survival remains low at 5%, and if you include all stages, 20%. Specifically in lung cancer, they're expecting about 7,200 new cases and 4,200 deaths from lung cancer. And just some rankings by how we do nationwide is that Georgia has a lung cancer incidence of 67.7 per 100,000 people, ranking at 32nd. Smoking rate of 16.1, ranking at 25th. 5-year overall survival of 18.1%, with about the same being diagnosed at an early stage. And there are 3.8 screening centers, which I'll talk a little bit later on, per million people, ranking at 31 out of 50. So you can see in general, we're a little below average in terms of lung cancer related statistics. Now, I don't want to be all completely negative, and that there are some positives. And this is from a paper that became very popular in the New England Journal, published this year, showing that the mortality from lung cancer is actually decreasing. From 2013 to 2016 among males, mortality decreased by 6.3%. From 2014 to 2016, decreased in women by 5.9%. And this decrease in mortality actually outpaced the decrease of incidence. So why is there mortality improvements? I mean, in most general terms, is because there's decreasing incidence and improved survival. Overall, less tobacco use leading to the incidence. Perhaps a benefit of lung cancer screening, not completely clear based on the dates of this study, but definitely because of better treatments, including targeted therapy and immunotherapy. However, there's much room for improvement. Now, I'm going to focus the talk on disparities, but just to kind of give a very broad overview of some of the advancements, we're very accustomed with this as lung cancer oncologists, in that we know that a significant portion of lung cancer population is driven by genomic mutations, what we call oncogenic drivers, meaning a specific mutation that happens that drives the cancer forward. And for many of these, we have targeted therapies. And this, probably the most famous one is EGFR. And this is just a summary of the study showing that EGFR TKIs are better than the old standard of care chemotherapy. And it's even advanced to the point now where we know that third generation EGFR TKIs, tyrosine kinase inhibitors such as osimertinib, are even more an improvement over the first generation agents. And now the FDA has approved at least 7 different targeted mutations for targeted therapy, with some exciting results in other categories. Now, we've heard about immune therapy, so I'm not going to go into the details, but know that immune therapy and checkpoint blockade has played an important role in the care for lung cancer patients. The Keynote-24 study showed that immunotherapy by itself was an improvement over chemotherapy for patients with high PD-L1. And it's not just the metastatic setting. A year of immunotherapy plus versus placebo after chemoradiation for stage 3 disease showed an increased survival. And actually at 4 years, almost 50% of patients were still alive. Now, moving on kind of to the crux of the talk, to discuss, disparities that still exist in lung cancer. Now, in terms of incidence, there's a little bit of conflicting data out there. You can see on the left from the CDC, if you take, both women and men and combine them, both white and Black patients at about this populations at about the same rate have the highest levels of lung cancer per 100,000 people, about 55. However, if you look in a slightly older review, looking at the SEER data, you can see that Black men by far have the highest incidence of lung cancer at 93 per 100,000 versus an average of about 70. And it's that average that probably brings you up to them about the same levels. And as a whole, just in case this was a question, there is not an increased tobacco use among Black males to account for these differences. Now, where there's not really any question is that there are disparities in survival in lung cancer. And you can see here in the graph that, again, the highest levels are among white and Black, but with Black men having significantly worse survival for lung cancer as compared to basically any other race, including whites, while Black females fared better. And this is obviously, as we've discussed at length during these talks, important for Georgia, where about 30% of the population, or 32% of the population is Black, with 58% being white and the rest made up of other ethnicities. So why do these disparities exist? Well, multiple reasons and explanations have been studied. One consistent cause that's been seen is the treatment for early stage disease. For early stage disease, the standard of care for eligible patients is surgical resection. Timely treatment has been proven over and over to improve overall survival and outcomes. And a seminal study that examined Black patients and white patients, 65 years or older, who were given a diagnosis of early stage lung cancer in the SEER database and then linked to Medicare, was performed. About 11,000 patients were included, 860 were Black, and the patients were well balanced between the arms. What you can see here on the graph on the left is that overall, any patients that had early stage lung cancer and got surgery did better than if you didn't get surgery. However, if you look at the survival by race, as the population taken as a whole, white patients had better survival. And in this study, controlling for various factors, 64% of Black patients underwent resection versus a higher rate of 76.7 for white patients. Black patients who underwent surgical resection had a 5-year survival rate similar to that of white patients who underwent resection. And they estimated that of the 77 more deaths per 100,000 Black patients, the majority could be attributed to lack of surgical treatment. So they just weren't getting the same treatment. Now, you might be thinking that, that's old data, 1999, things have changed a lot by then, but unfortunately, it's not just an artifact of the past. And a recent study published in CHEST 2019 showed that in the NSCLC study, which is a CT screening study I'll talk about, patients with stage 1 cancer that wound up undergoing surgical resection with white men and white women at 93%, Black women at 90%, and Black men only at 65%. So to turn attention to CT screening, a relatively new modality, 2 main studies got this approval for widespread use. The first one was the NLST study. This was for patients with at least a minimum of 30 PAC years, were followed yearly with either chest X-ray or low-dose CT scan. 50,000 patients were included, and what they showed is a 20% decrease in lung cancer mortality if you underwent CT screening. Nelson study, a very similar study, 13,000 men, which was the primary endpoint, and 25,000 women, 5.5 years of screening, smoking history, and they showed 2.5 deaths for patients that underwent screening per 1,000 person year versus 3.3 deaths per person year if you did not undergo screening, with a cumulative rate ratio of from death from lung cancer at 10 years of 0.76, a little lower in women. And that led the USPSTF to recommend annual screening for lung cancer with low-dose CT for patients 50 to 80 years who had a 20-pack year history and currently smoke or have quit within the last 15 years. And how do we do in Georgia? Once again, we're a little below average, where we screen 4.4 of high-risk individuals, ranking us 28th. And Medicaid, fortunately, does cover screening in Georgia. It doesn't in every state. One thing to point out here is overall, as a country, we're not doing enough screening. I mean, even the best of the institutions are only screening about 12% of eligible patients. However, there are just disparities in CT screening, even with these guidelines. So when utilized, CT screening seems to demonstrate actually better results in Black patients than white patients. Now, the sub-analysis of the NLST study that I just described, of which only 4% were Black, had that the Black patients had increased lung cancer mortality and all-cause mortality, but when they underwent CT screening, they actually had increased benefit from the screening. However, in practice, Black patients are referred to and receive low-dose CT screening at lower rates than white patients. One potential reason for this is that current eligibility for screening is less likely to include high-risk Black patients, as they, in general, smoke less cigarettes per day, start smoking at a younger age, and develop lung cancer at a younger age. And other reasons for this racial gap in CT screening is such things as less access to healthcare, implicit bias on the part of physicians and systems, and increased distrust of medical institutions, et cetera. Okay, so I'm going to switch gears a little bit and talk about a study that we performed here at Emory, where we want to look at disparities in lung cancer, or we know that disparities in lung cancer incidence, mortality, and treatment exist based on race. And the molecular profile, especially now, but even when we completed the study a couple of years ago, was well defined for Asian and Caucasian populations, but minority populations were lacking. And we think, and the prevalence of oncogenic drivers in lung adenocarcinoma may vary by race, very well described in the EGFR, where we know at least 40 to 50% of Asians have EGFR mutations, while it's only 20% in Caucasians with lung cancer. So the questions we had are, is the mutational profile of pulmonary adenocarcinoma consistent across race ethnicities? And does race influence the use of targeted therapies on overall outcomes? Just kind of move along so we don't have time for questions. We based this off a study group called the Lung Cancer Mutational Consortium, which studied patients between 2009 and 2012, used the panel that you see here, which now we do next generation sequencing, but that's what we used at the time. And the primary outcomes were driver frequency, amount of patients treated with target therapy, and overall survival. What they showed is this kind of breakdown of mutations found. It's common knowledge at this point among patients treated lung cancer because of how much work has gone into this. At the time, they showed that KRAS 25%, EGFR about 20%, and ALK a little high at 8%. Importantly, they showed that patients that had mutations that got targeted therapy did better than patients that either didn't have a driver mutation or did not get had a mutation, did not get targeted therapy. So we broke this down by race, which led to smaller numbers of non-Caucasians, but they were well balanced between the groups, with Caucasians having a somewhat higher smoking frequency. And what we showed is that Asian, largely driven by EGFR, but Asian patients had the highest level of mutations at a little above 80%, with African Americans at a lesser at 53% within their lung cancer tumors. And when we can, this pattern still existed when we controlled for smoking, which is non-smokers are more likely to have mutations. Now, this did not, in the African-American population, this did not reach statistical significance that we found. The breakdown was relatively even by race, Asians having a higher percentage of EGFR and Caucasians having a higher percentage of KRAS. in these small numbers we found, because when you break them down to groups, they're relatively small, but we did not find a difference in the context of this clinical trial of the care patients received by mutation, nor a difference in overall survival. Again, very small numbers here, but no difference in survival by mutation by race after controlling for age and smoking. So I just want to so the study conclusions, we saw significant differences. We're seeing the prevalence of oncogenic drivers by race, Asians most frequently and Afro-Americans the least. Caucasians and Asians had a higher percentage of KRAS and EGFR mutations. Asians were the most likely to receive target therapy driven by EGFR. And I think kind of, especially in the context of this talk, the most important conclusion is that race did not influence overall survival in our study, but mutations were present in all races. And so every advanced non-squamous non-small cell lung cancer should receive genomic testing as standard of care. And there's some evidence out there that minorities are tested at a lower frequency than Caucasians. So so just to finish up, I put together this slide just for this talk, very non-scientific slide where I just pulled out 4 of kind of the landmark trials over the last 5 years or so, a little longer for the NSLT, that kind of defined a certain treatment modality, change practice, and reported how many participants were there by race. And Dr. Carthon did a good job in his talk talking about this. But I mean, if you just see the percentage of patients that are African American or Black on these studies, 1%, 2%, 1%, with the highest being 4.5 on the NST, clearly better representation is needed to close these racial gaps. We do better at Emory, as has been laid out before. Phase 1 clinical trials have 20% enrollment from Black patients. And just to conclude, so the prevention and treatment of lung cancer in the US is improving, but still a significant cause of mortality and morbidity. Racial disparities unfortunately still exist, complex set of reasons causing that, biases, socioeconomic, and actually studies that have looked at implementing protocols to specifically address these biases have actually shown success at decreasing racial gaps. CT screening guidelines should be examined to see if they can better capture minority populations and needs to be more widespread. Crucial work is needed to improve the treatment for minorities in early stage disease. Everyone needs genomic testing that's non-squamous advanced non-small cell lung cancer, and more diverse representation is needed in lung cancer clinical trials. And that concludes my talk. Happy to take any questions. Thank you very much.